Environment is important. Does your hospital has the right robotic logistics to do robotics in a safe and a good way? Do we have the good robotic team? Do you have the trained nurses, bedside surgeons, anesthesiologists around you? And there is training in different steps. The real learning curve is to learn how to do robot-specific surgical procedures.
In my practice, what I try to do is I try and keep things standardized. It's really important to do the same thing time and time again. Unless and until I'm struggling, I'll change. But I try to keep the things standardized so that when he's doing, he's setting up the case or things like that, I don't have to worry about the thing. So that's what I do.
It is rightly said that, as the surgeons keep moving ahead, the anesthetists also have to keep in pace. So otherwise, they would be falling far behind them.
Every place is unique. Every institution has their own unique needs. You also need an anesthesia team that's familiar with laparoscopy and familiar with robotic surgery, and that means then also pediatric surgery. It's good to do a team dry run before the first few cases, and also to do a team debriefing after the case to say how things go, what went well, what didn't go well, what can we do to improve it.
These are issues which will come when you start a program, and therefore anesthetist, surgeon and his colleague, these three are the vital components of a program.
We always prefer to have the surgeon in the OT prior to induction. A few things which help us are, one is we know the right site has been marked. Secondly, quite a few surgeons prefer to do a bronchoscopy before doing a lobectomy or a pneumonectomy. So, we want to put in a single lumen tube, do the bronchoscopy, and then change the tube to the double lumen tube is required. And then during positioning, it's always better to have the surgeon in place because you don't want them coming afterwards and telling us that, the position is not right. I mean, you need to change all the things after your positioning and all the lines are in place. Always plan for a thoracotomy and have the set ready in the OR. An emergency for drill for undocking of the robo should be in place just in case if there is a catastrophe. We have to know that how the robo can be undocked within seconds.
I think in all of this is that the surgeon must be patient. Honestly, if you stand on your anesthetist's head,
he must be present.
Yes. The thing is, you call him, check the thing, get your thing done, then send him out for a cup of coffee, put your tube in place, do what you have to do, and then call him again.
Honestly, I never, ever hassle her for the time that she takes. I just, say, carry on, because the extra half an hour she will take before will make my life easy for the next 3 hours or 2 hours, whatever. So it is really important that the surgeon must be patient. Intraoperatively, if you're having problems, please just relax and say, take your time. Do whatever maneuvers you have to do it. Sometimes in a VATS case, when we've lost the single lung ventilation, it does happen because the tube manipulation happens. There have been 2 cases that I remember over the last many years. I have actually closed the patient. I just put a couple of stitches and a couple of dressings, told the anesthetist, turn the patient back over. They did whatever they had to do. They couldn't manage. They lost the ventilation. We turned the patient back in, took all the drapes off. We scrubbed out. It was safe for the patient at that stage. Put the patient on the back and again re-put in, start from fresh, and we got the isolation, turned again. That actually saved the patient having a thoracotomy and a messy situation. So really the surgeon has to be patient. Do you agree, Dr.
2, 3, absolutely. When they are patient, when we are learning, why shouldn't we be patient?
Absolutely.
That's in a light vein. But the thing is that the success of thoracoscopy or robotic depends on achievement of one lung ventilation. If the tube is not placed, and thoracotomy you can still do in a ventilating lung,
Yes.
but thoracoscopy or robotic you just cannot enter in a ventilating lung.
See, one point that has come out of this discussion is that not just the anesthetist should know all the maneuvers that are possible.
Yeah,
the
very
surgeon
right.
should
Very
know
right. Actually, yeah.
what are the maneuvers that are possible. Because when they are struggling at the top end, sometimes a kind word or a kind comment from the surgeon side, why don't you do this, will actually salvage the situation. So it is really, really important for surgeons to understand how the double lumen works, what are the various maneuvers. Of course, it comes with experience, but it is important that you understand all these techniques.
The anesthetist needs to be trained adequately in lung isolation techniques, fiber optic bronchoscopies, and one lung ventilation, as well as, they should be aware of, what are the complications which they can face when such surgeries are going on.
Bean bag is absolutely
That's what we are after, Dr. Khan,
vital.
to procure
No,
it
if
for
we
us.
if we spend 10 crores on a robot, there's no
Definitely,
reason why
yes.
a lakh or lakh and a quarter should not be spent on bean bag.
The whole elephant passes and it's always the,
The
tail.
tail. Which
Yes,
is difficult.
yes. We spend a massive amount.
Yes.
And mind you, the anesthetists always say that you spend heavily on surgical equipment, but when it comes to anesthesia, you suddenly become a miser.
See, the surgeon sitting at the patient side knows what is happening probably at the console, but the surgeon sitting at the console is not aware what is happening at the patient side. So it is the proper communication and the understanding between the two
Sure.
to make the procedure successful.
It's not just a trained anesthetist or a trained surgeon. Another trained person is absolutely vital, and as you rightly said, after the anesthetist is done with his or her job, it's your colleague who takes over, and he's the one who actually decides all the ports and this, that, and actually manages the show there while you are away on the console.
Sir, you said that the robotic cart comes in 15 degree from the head end.
In
You
a
are starting from the
lobectomy.
right side of the patient,
I'm standing
From the
at
anterior aspect.
I'm standing at the back of the patient.
at the back of the patient.
Yeah,
Where is the anesthesia cart?
Anesthesia cart is at the foot end.
Foot end.
Foot end. We clear the whole head. We clear the whole head area, and we give an extra long tubing which goes all the way to the face. It's a challenge for the anesthetist. That's why you need two anesthetists in table for a lobectomy, because one has to be at the foot end with the monitors, and the other one has to be at the head end to make sure tube issues and things like that. So it does require more personnel. It does require more expertise. Should be done only in specialized centers. I think so. Only people who are doing them regularly should do it. Does not mean that we are not encouraging more people to do it. I think everybody should start, but do it in centralized institutes rather than small nursing homes.
So the important message is that failure to check the equipment properly before induction of anesthesia is responsible for 22% of the critical incidents that occur during anesthesia. So we have to ensure that the equipment is working properly and giving us the right information.
You have to put up a lot with us acquiring new techniques, and sincere thanks to all of you as an anesthetist for that.
Thank you.